Hi everyone. Today we're going to continue our lecture regarding the management of the impacted lower third molars. This is the second part that will deal with the surgical steps in this surgery. So, in the beginning, what are the general procedure? What are the steps we need to follow? In order to manage an impacted lower third molar, we have 5 steps. These are gaining access by flap elevation, so we need to elevate the soft tissue that cover the impacted lower third molar, and then we need to remove the bone that cover that impacted tooth to gain access to the impacted tooth. Following that, we need to section that tooth if needed, and then we need to deliver the tooth with minimum forces. Following the completion of all that, and then we need to adopt several stages to prepare the wound for closure, and then we close it actually. Okay? The procedure of third molar surgery, it's an open surgery, so we open the bone, okay, to gain access to the impacted lower third molars. So since we have a surgical procedure that deals with flaps and bone removal, it need to be sterile. So all the procedures need to be done with personal protection regarding eye protection, eyeglasses, mask, head cups, and sterile gowns and surgical gloves. The patients also need to be prepared properly by disinfection of the skin, disinfection of the oral mucosa, head cap, sterile towels, and so on. In order to gain access, we have different flaps. All we can do is to select between them according to that specific case. We all can do big flaps, but there is no need to do big flaps. We have to minimize the site for the surgery as small as we can do to manage the tooth properly. We can either do an envelope flap or we can use a two-sided flap. Which one would we use? It depends on the depth of the impaction and the amount of bone that is anticipated to be removed. An envelope flap usually starts from the distal side to the third molar, around the distal gingival margin, and then within the sulcus. So it is like intrasulcular incision that extends beyond the second molar till the mesial papilla of the first molar. This is called an envelope flap. It doesn't have any releasing incisions. This is a side, this is a top view, okay? This is also a top view. This is the lingual nerve, and this is a side view that you can see that we have a long flap that hasn't any releasing incision. This is called an envelope flap. Another way to do that is we can place a releasing incision to make a two-sided flap. So also from the distal side and over on the area above the third molar, and then to the distal margin of the second molar, around within the sulcus, and then to the mesial papilla of the second molar, and then we can place a releasing incision. This releasing incision shouldn't be longer than 6 millimeters, because when we reach deep within the vestibule, there are number of blood vessels that might get traumatized and cause bleeding, extensive amount of bleeding. So we limit the releasing incision to about 6 millimeters in height. Okay, and here we have a two-sided flap. This will give more access and also will enable the operator to do bone removal to much more extent than what we can do within the envelope flap. So depending on the depth of your impacted third molar, you can choose between either an envelope flap or a two-sided flap. Here are clinical photos have been taken from this book. You have here the reference. It's an amazing book that have multiple clinical picture and schematic diagrams and detailed description for each step you can do in oral surgery. Here, a Bart Parker handle number 3 with a 15 blade on it. You can see an incision that has been placed on the area around the third molar, impacted third molar. This is an envelope flap. This is the complete incision extending from the distal margin above the impacted third molar, around the distal gingiva of the second molar, and then within the sulcus of the second molar, and then it goes till the mesial papilla of the first molar. Here you can see the whole flap being reflected, and then here you can see another retractor that protects the lingual side. Following and gaining access to the impacted third molar, we need to remove the bone that covers the occlusal part. So in the beginning, we use a surgical handpiece with a Fisher burr or a round burr on it, preferably a round burr on it, and then we remove the whole bone that covers the occlusal part of the third molar. Following gaining access to the occlusal part, we start to remove bone from the distal margin as well as from the buccal margin till the level of the cemento-enamel junction. So here we have the whole crown being exposed for the surgeon to allow the sectioning or the delivery of the tooth, whatever we need to do. Sometimes we don't remove the whole buccal plate, as you can see here. Sometimes we can use a tunnel just to make a space between the cortical plate from one side and the tooth from the other side. So a Fisher burr can extend around the impacted tooth to prepare a tunnel. This tunnel preparation will aid for the delivery of the tooth and make a point of application for your elevators. All these bone removal need to be done with a surgical handpiece, surgical burrs, and under continuous irrigation of saline. This will prevent the bone being overheated, and also the saline will wash the flutes of the burr and allow more cutting efficiency of the burr. We need to retract the soft tissue and protect it with retractors just to prevent any trauma from the burr to the soft tissue. So we need to protect, reflect, and protect all the soft tissue during this procedure. We usually don't remove bone from the lingual side to prevent trauma to the lingual nerve. Sometimes we do need to remove bone from the lingual side, but in most instances we avoid that just to prevent a trauma. And if we need to remove bone from the lingual side, we need to protect the lingual soft tissue by a retractor to retract the whole flap with the lingual nerve enclosing within it, okay, to prevent its trauma by the burr. This is clinical photo about bone removal from the occlusal part, and here you can see, actually you can see the handpiece removing bone from the distal part as well as from the buccal side as well, okay. Sometimes we do need to section the tooth. In this instance, we have different scenarios. In this instance, we have a mesio-angular third molar. You can see we can use a surgical handpiece to remove the distal part of it, following the removal of the bone on the distal side and the buccal side and the occlusal side. We can cut a small piece from the crown from the distal side, okay, before the delivery of the tooth. This will create a space distal to the tooth that can allow the delivery of the tooth to that direction. If we have a horizontally impacted tooth, lower third molar, the whole crown needs to be sectioned. This will create enough space that have been occupied by the crown in order to deliver the roots within this space. A distal angular also needs bone removal from the occlusal side as well as from the distal and buccal side. In the distal angular tooth, this is the most difficult situation we encountered because the line of withdrawal will run within the ramus. So extensive amount of bone need to remove and the whole crown need to be sectioned. After we prepare the crown for sectioning, we can use the elevator to fracture the crown. So we don't actually section the crown from the whole width, from the buccal to lingual. We only section about 2/3 of it and leave a shell on the lingual side. This would protect the vital structure on the lingual side, the lingual nerve, from being cutted by the surgical handpiece and burr. So we only cut about 2/3 and then we insert our elevator and fracture the remaining part. Following removal of the crown, we can remove the roots, the retained roots, by, for example, here we have a crier elevator in action to remove the roots within the space that we have just created that have been previously occupied by the crown. This is a distal angular. Here you can see the handpiece, clinical photos, the handpiece cutting, doing a crown sectioning on a mesio-angular lower third molar. So after we cut about 2/3 of the crown, we can use a straight elevator, as you can see on the other picture, and put it within the slot or the groove we have created by the handpiece. And then once we rotate the elevator, we can fracture that segment and create a space for the delivery of the other part of the tooth. These pictures also taken from this book. You can refer to it for a detailed description for this procedure. So we have sectioning of the tooth on one side and bone removal on the other side. We can remove as much as we can from the bone without sectioning the tooth, but we'll create an enormous defect within the mandible. We can section the tooth into tiny pieces and avoid bone removal, but this also will make the procedure very long, and making the tooth into these tiny pieces might complicate the surgery. So which one the operator should choose? Tooth sectioning or bone removal? Okay, here there's no black and white in it, so we have to balance in between. We have to section the tooth into a reasonable amount of pieces and remove as minimum as much from the bone. And there is an old saying that I have once heard, that the tooth belongs to the surgeon and the bone belongs to the patient. So after we finish the surgery, we can have the tooth, but the bone needs to remain within for the patient. So we remove as minimum as bone as we can, and we section the tooth into a reasonable amount of pieces. Okay, so within this balance, we hopefully have a procedure that have minimum mortality and morbidity. Delivery of the tooth with elevators. Following the sectioning, okay, it's time to deliver the tooth. So we need to take the tooth out of its socket. This can be done by elevators as well as forceps in some instance. But in most common instance, we use the elevator, as the third molar need to be removed without too much resistance. Okay, so we have the straight elevators, the luxator here you can see, okay, and the Copeland chisels. We also can use the criers. The criers can be used to deliver of the roots, and sometimes the crier can be used to deliver the whole third molar. Winter T-bars, I wouldn't suggest using them. It can be used, winter T-bar can be used in third molar surgery, but winter T-bar can generate enormous amount of forces that sometimes, if having been used cautiously, can fracture the mandible. So for me, I wouldn't use it. I would use the luxator, Copeland chisel, and the pair of criers for the third molar surgery. Winter T-bars can sometimes cause complications, so we no longer use it anymore. Here you can see a straight elevator that is in action to deliver the tooth. On the other hand, here you can see a crier that is being used for the delivery of a whole third molar. On this side, you can see the flap being retracted by a Minnesota offset retractor, and here you can see the Weider tongue retractor retracting the tongue. Following the delivery of the tooth, forceps, as we said, can be used to aid the delivery in some instances. We need to use a bone file to smooth this edges of the bone, because once we used the handpiece and the burr on it, sometimes we have sharp edges from the area of the bone that we have just cut it, and we need to smoothen this out with a bone file just to allow the post-operative period for the patient to be more comfortable. Sharp edges can be painful for the patients. It can sometimes cause wound dehiscence, so it's best to take a little time to smoothen these edges, and the patient would very much appreciate it in the post-operative period. It will minimize the post-operative pain, and also would make the post-operative pain as much low as can. We need to irrigate the area, so we use a warm, normal saline to wash out all these bone chips that have been generated by the handpiece or the bone file, as well as sometimes tiny pieces during the tooth sectioning that might remain left beneath the flap or within the socket need to be all washed out. These tiny pieces might cause infection, delay the wound healing, so we just take a little bit of time, and these little things like bone smoothing, irrigation will make the surgery for the patient as much as comfortable as. So following the irrigation and bone smoothing, we need to remove the follicle. The follicle, if remain within the surgical site, can cause cystic changes, so it's better to remove the follicle. Never leave the follicle behind. For this procedure, we need to use a curate, a periapical curate, which is a small surgical curate, a hemostat to allow the grasp of the follicle, and with a constant pressure from the hemostat to withdraw the follicle, we can use the curate to remove its adhesion from the bone. Following the removal of the dental follicle, we also can do another irrigation for the area, and then we can use sutures. It's best to use uninterrupted sutures with spaces in between to allow oozing of the blood and prevent the development of a hematoma. Here you can see that sutures are placed on the papilla just to reposition the flap properly, and also on the distal side, distal to the second molar. Hemostasis, following the application of suture, I would usually wash the area with saline, also this tongue of the patient, vestibule, and also I would dump a piece of gauze and wash the patient's face from the disinfectant solution, the betadine sometimes we use to disinfect the skin. After we clean the area, we place a damp gauze on the surgical site and ask the patient to bite on it. I would also give the patient a cold pack to place extraorally and wait for about a few minutes, and then I would check the surgical area again. If there is obvious bleeding, I would manage it. Sometimes we need to place more sutures, sometimes the sutures are loose, we need to cut it and place another suture. Sometimes we have blood vessels that have been cutted, especially if it is a long releasing incisions, we need also to manage it. So we need to make sure that hemostasis have been achieved. Sometimes the patients on antithrombotic medications, for example aspirin or warfarin, we also to take extra caution about those patients. We need to make sure that bleeding have stopped before the patient leave the dental office. Okay, so this is the steps in regarding the management of an impacted lower third molar. If you have any questions, just feel free to post it down in the comments. I will be more than happy to answer. Thank you.